Bismillahirrahmanirrahim. First of all, on behalf of Indus Hospital and Health Network, I welcome to all in Obstetric and Gynecology Scientific Session Icon 2022, which has a theme of Beyond the Call of Duty. Let's begin with the recitation of Holy Quran. Bismillahirrahmanirrahim. Qul huwallahu ahad, Allahus samad, lam yalid walam yulad, walam yakul lahu kufuwan ahad. Now, I would like to invite Dr. Farah Bari to have her formal welcome note. Dr. Farah Bari is a DGM and head of Sheikh Said Memorial Hospital, Indus Hospital and Health Network. So, over to you, Dr. Farah.
Assalamu alaikum. On behalf of Indus Hospital and Health Network, Department of Obstetrics and Gynecology, I welcome you all to the biennial conference ICON 2022, where theme of our conference is Beyond the Call of Our Duty. Giving a little background, Sheikh Said campus, which is maternal and child health campus of Indus Hospital, started its journey in 2015. As a small maternity home in 2015, we have, mashallah, grown up to a center of excellence for mother and child, where all sort of obstetrics, gynecological procedures, including minimal invasive surgeries, oncological surgeries, and an ICU facility. We are humble to God regarding COVID-19. COVID-19 started in December 2019, and in last 2 years, Alhamdulillah, we have been able to cater more than 12,000 admissions, more than 200 plus COVID positive deliveries were conducted, more than 12,000 admissions were done, and I will take this opportunity to thank all my clinical staff, which under the leadership of Dr. Samia Shuja, work with resilience, and they perform their duty. Our doors for our patients were open. All sort of obstetrics were continue. Our clinics were open through teleconsults. Our ER was open, and we were able to continue our services to our patients. Meanwhile, I'm also thankful to the management of Indus Hospital, who timely provided the equipment that we need, the PPEs, and the pandemic leaves, which I think no public sector hospital gave paid pandemic leaves. This is an excellent opportunity to thank all of them, the clinical staff, the non-clinical staff, the support staff, through which we were able to achieve our goal. In the end, the ICON 2022 is a learning opportunity for all of us. And I just want to give a small message to our colleagues, to our residents, to our learners, that in addition to their skills, please focus on the soft skills, on the attributes which help us to become a better person, to become a better doctor. जब तक हम अपने एक अच्छा इंसान नहीं बनेंगे, एक हम अच्छा क्लिनिशियन और एक अच्छा नॉन क्लिनिशियन, जो कि एक जो हमारा टैग लाइन है इंडस की, क्वालिटी केयर फ्री ऑफ कॉस्ट, वी विल नॉट बी एबल टू अचीव आवर गोल. So I'm humbled to be part of this institute, and inshallah, I hope that this will be a great learning opportunity for all of us, and I welcome all my participants to open up this session. Thank you.
Bismillahirrahmanirrahim. I'm Dr. Hiba Ashraf, Director of the Primary Care Program, and I've been invited to give a talk on role of primary care in reducing maternal mortality. So, about maternal mortality, maternal death, which is basically a death anytime during pregnancy or 6 weeks after the delivery, is the leading cause of death in women between ages 15 to 49 years of age. There are 5 major causes accounting for 2/3 of the maternal mortality, which are hemorrhage, sepsis, unsafe abortions, eclampsia, and obstructed labor. There are various indirect causes to maternal mortality as well, which account for another 20%. These are due to pre-existing conditions during pregnancy, which are either exacerbated or worsened, like malaria, viral hepatitis, etc. So some facts about maternal mortality. Globally, maternal mortality ratio has declined approximately 38% from 2000 to 2017, from 342 deaths per 100,000 live births in 2000 to 211 in 2017. Approximately 800 of women still die every day worldwide, mostly due to preventable or treatable causes of which are related to pregnancy. And 99% of all those maternal deaths worldwide are from the developing world. From amongst the developing world, over 80% of those maternal deaths are in either sub-Saharan Africa and South Asia, which accounts for approximately 68% and 19% of maternal deaths, respectively. If we talk about South Asia, they were able to achieve the greatest overall percentage reduction in maternal mortality ratio, with a reduction of 59%, from 395 to 163 maternal deaths per 100,000 live births. If we talk about Pakistan, a survey done in 2019 called Pakistan Maternal Mortality Survey showed the maternal mortality ratio for Pakistan to be 186 deaths per 100,000 live births for a 3-year period before the survey was published. This was a significant reduction from 276 deaths per 100,000 live births in 2006 and 2007. The causes of death remain the top of the list is still hemorrhage, and 29, which is 41%, and 29% die due to hypertensive disorders. Now, how many times have you come across such scenarios? For instance, a woman was brought to the hospital in semi-conscious state. Family informs that she had home delivery 6 hours ago by an unskilled attendant, and was rushed to the hospital as the bleeding wouldn't stop, a hospital which was many kilometers away from her home. We come across these scenarios in the rural settings pretty often. Similarly, in rural as well as urban settings, pregnant women waiting for hours for a routine antenatal checkup in an extremely busy outpatient clinic of a hospital is a scenario that we are very familiar with. At least I remember a lot of such instances. Now, would these cases arise if a good quality, dependable primary care was a routinely available part of the national system for delivering healthcare? Now, this brings us to a question of what exactly is primary care. Dr. Barbara Starfield was somebody who was an American pediatrician by profession, but she has done a lot of work on primary care. She, in fact, is one of the biggest advocates for primary care. She defined primary care as a provision of first contact, person-focused, ongoing care over time that meets the health-related needs of people, referring only those problems too uncommon to maintain competence, and coordinates care when people receive services at other levels of care. In 2008, World Health Organization extended the definition to include community in the primary care. What are the health benefits? Why are we talking about primary care? What are the health benefits of primary care? Again, Dr. Starfield published a mass of evidence to show that health systems based on strong primary care delivers better population health outcomes at a lower cost. A lot of the countries which are primary care oriented, they have fewer low birth weight infants, lower infant mortality rates, lower maternal mortality rates, and higher life expectancy at all ages. There are quite a few success stories in Bangladesh, China, Cambodia, Nepal, etc., where small interventions were able to lead to a very significant decline in maternal mortality at the primary care level. One such example is published in a study in BMC in 2020 in China, that just by increasing one primary care physician per 10,000 population was associated with 5.26 per 100,000 live birth reduction in maternal mortality, 0.106% decrease in low birth weight, and 0.4% decline in perinatal mortality per thousand live births. So that is just by increasing one primary care physician per 10,000 population. There are several contributors to elevated maternal mortality and morbidity in Pakistan. The top being the lack of healthcare facilities available for the population near their homes. Other factors are lack of education, malnutrition, poverty, prevalence of violence against women in rural areas, and socioeconomic factors. Now, what are we doing at Indus Hospital and Health Network? We have a very robust primary care program in a few districts of Pakistan, which works in alignment with vision and mission of Indus Hospital and Health Network. It focuses on creating an excellence-driven, comprehensive, compassionate, free of charge, and replicable healthcare system accessible to all. We work through hub and spoke model, where the hub is through presence of family medicine at the hospital-based sites, and spokes are independent primary care facilities across in the vicinity of 3 hours of that hospital. The values of primary care program focus on integrity and transparency, respect, dignity without discrimination. Accessibility is one of the major things that we work for. Excellence in quality service and social responsibility. We are currently in 9 districts of Pakistan. We have 12 independent primary care facilities in both urban and rural areas, 5 first-level hospitals, and 6 tertiary-level hospitals across Pakistan. So this is from Karachi to Kashmir in 9 districts. One of our flagship program, which focuses on integration of maternal and child health services in primary care program, as within the primary care program, we see about 30 to 40% maternal and child cases. Our flagship program of community midwifery was piloted in one of our primary care sites in rural parts of Pakistan, of southern Punjab, which is Bhong, Rahim Yar Khan. The objectives of that program were reduction of maternal and newborn mortality and morbidity through quality care, free of cost pregnancy and childbirth services, free of cost family planning services, leading to reduction of infant mortality rates through improved birth outcomes, improved infant feeding practices, and increased immunization rates. The program focuses on delivery of antenatal care, safe delivery services, postnatal care, and newborn interventions. In the places where only antenatal care is given, we do nutritional counseling, folate and iron supplementation, ultrasound for fetal well-being, anemia correction, management of respiratory tract infections, tetanus toxoid immunization, family planning, and danger sign awareness, and where needed, referrals. Safe delivery services in those areas where we have delivery done by community midwives. We have round-the-clock birthing services, on-call backup support for decision-making and delivery complications, online decision-making mechanism for birth delays, and ambulance availability for intrapartum emergencies. In the postnatal care, we cover early initiation of breastfeeding, postnatal observation of mother-baby for 6 hours, immunization counseling, lactation clinic, postnatal and well-baby checkups, family counseling of postnatal danger signs, and postpartum family planning. And we do not stop at that. We do have newborn interventions where we have neonatal resuscitation trained staff. We have kangaroo mother care, nutritional support, lactation clinic, Injection vitamin K is given at birth, and newborn care packages are given for hygiene and infection prevention. So up until now, the program was initiated in February 2019, and till December 2021, we have done about 20,500 antenatal checkups. Average number of antenatal checkups in pregnancy is 4.5. We have conducted 845 safe deliveries. 803, which is about 95% of the newborns, were breastfed. 2,000 family planning counselings were done. There were no cases of maternal mortality reported at our community midwifery site, and but we did see cases of stillbirth and neonatal mortality at our site, which were 5 of them. So Boat Clinic in Rajanpur is about 1.5 hour away from our Bhong setup. The need for initiation of this clinic was identified when we saw a lot of women from this area coming for their delivery management at Bhong Hospital, and they only came there for delivery. They did not have any antenatal checkups, and they had to travel a long way for availing those services. Now, this Boat Clinic is in an area of Indus River, which is very remote, and people do not. When we started this clinic, people did not even had an access to a doctor. They'd not seen a doctor for approximate. Some of them had not seen the doctor for 70 years since Pakistan came into existence. And so when we started these services up until now, we've seen 200 plus antenatal checkups are done. These patients actually come for their deliveries at the Bhong setup still. 150 plus women have been given lactation management appointments, and more than 120 women have been counseled on family planning. The outcomes of midwife-led model of care, there has been natural birth practices, increased chances of vaginal deliveries. The antenatal and postnatal checkups and continuity of care has reduced the risk of preterm birth and perinatal mortality. The patients are identified with being high risk and referred timely for care at the nearest hospital, which is about 1.5 hours away in Rahim Yar Khan. Personalized, respectful maternity care is given by the midwives, which has led to higher levels of satisfaction with the ANC antenatal care services and birth process. There is large reach of community midwives, which has increased the access to care in low resource setting. And because there has been task shifting, there is lower cost of care per woman. So to conclude, I believe that expanding the quality and quantity of primary healthcare services for maternal health care in remote and rural districts is the need of the time. Educating women and the community about the nutritional needs and the introducing child spacing for maternal and neonatal care is essential. There is a need for awareness camps and education of women to address social determinants of maternal mortality and morbidity in the remote areas. Capacity building, routine monitoring, and accountability of healthcare staff to ensure quality of services. We need to learn from success stories of the countries who've achieved low maternal mortality despite them being the countries with the same challenges as Pakistan. And we need to reevaluate the healthcare infrastructure, and there should be reallocation of funds and budget to primary care to avail to be able to get lower maternal mortality rate and improved social determinants of maternal mortality and morbidity. Thank you.
Okay, thanks a lot, Dr. Hiba, for such an elaborative highlights on primary care services, which is provided by Indus Hospital and Health Network. And the role of primary care services definitely cannot be denied. It's a backbone of any healthcare system. Now, our next guest speaker is Dr. Uzma Chishti. Dr. Uzma Chishti is an assistant professor, obstetric and gynecology department, and associate director, gynecological
Assalamu alaikum,
oncology
everyone.
fellowship program at Aga Khan University Hospital. She will enlighten us regarding gynecological cancers in Pakistan, which is definitely a calamity. As we all know that January is a month of cervical cancer awareness, and it's a great time to talk about the prevention of the gynecological cancers, especially cervical, across Pakistan, and take measures to reduce the burden of by taking preventive measures. So, Dr. Uzma.
So I'm Dr. Uzma Chishti. I'm the assistant professor and gynecologic oncologist at Department of Obstetrics and Gynecology, Aga Khan University Hospital. First of all, I would like to thank the organizers to give me this opportunity to talk on a very important topic, which is gynecological cancers in Pakistan, a calamity. So I would like to disclose that I don't have any conflict of interest. So today in this presentation, I'm going to talk about the disease burden in Pakistan, the history of gynecologic oncology subspecialty in a little brief, and challenges of establishing it in Pakistan. Further on, I would like to talk about establishing fellowship training in Pakistan, and in the end, my conclusion and my wish list. So as we all are aware that gynecological cancers constitute about ovarian, uterine, cervical, vaginal and vulval cancers. I'm going to talk about the ovarian, uterine and cervical cancers in a bit detail, which are the common and constitute more than 90 to 95% cases of the gynecological cancers. So in Pakistan, if we look at the statistics of 2020 by the International Agency for Research in Cancers, by WHO, so we have cervical cancer at the third most common cancer in females, and the ovarian cancer comes at the fifth number if we talk about the females cancers only. So looking at the age standardized incidence rate per 100,000 women in our country in 2020, cervical cancer is the fourth most common cancer amongst the female after the breast, colorectal, and lung cancers, and it constitutes around 14 cases per 100,000 women in our country. Ovarian and corpus uteri cancers each constitute about 6 cases per 100,000 women in our country. The important thing which I would like to highlight here is that if we look at the mortality from all these cancers, so it can be very easily driven out from these statistics that the mortality in cervical cancer and the ovarian cancer are more than 50% in our country of all the cases which are presenting to us. So talking about the cervical cancer, it is the third most common cancer in our country, and overall worldwide, the incidence of cervical cancer has gone down because of the good and established screening and vaccination programs, which I'll be talking later in my slides. In worldwide, the cervical cancer is one of the top 10 cancers, but the incidence is 3.1% only. So looking at the ASIR again, the major chunk of these cancer cases has been taken by the Eastern and African countries because of the non-availability of vaccine and the screening programs. So talking about the Pakistan, so as I already said, the third most common cancer. So the incidence of this cancer is 5.5%. So, according to the global cervical cancer crisis card established by the WHO in 2013, Pakistan ranked seventh amongst the death count for cervical cancer. And cervical cancer kills 20 women daily in Pakistan. So this is where we have to work a lot. And this is a very eye-opening statistics for Pakistan. So though the preventive strategies, as I already mentioned, vaccination and screening programs are very well established for a number of decades now, and all the Western countries have reduced their incidence and mortality from cervical cancer to the negligible because of the implementation of vaccination and screening by pap smear and HPV DNA test. Unfortunately, in our country, there is no national health screening programs, and the vaccination was available for a very short time. It's not available nowadays, so we are still waiting for them to come back. So, a study which is published in 2017 about the knowledge, awareness, and practices of cervical cancer in Pakistani women shows that less than around half of the women who heard about cervical cancer, amongst them only 50%, 47% had heard about pap smear, and amongst them also only 73% had gotten a pap test, and a total of 25.5% of women out of the 61.2% knew that a vaccine existed for prevention. So the awareness is also required amongst the healthcare professionals and the public. Awareness is much of the need of the time. So going to the uterine cancers, it is in the worldwide, it is the sixth most commonly diagnosed cancer in women. However, its incidence is lowest in most African and South Central Asian countries. The point of concern here is that the incidence is at rise in South Africa and several countries in Asia because of the prevailing obesity and physical inactivity in our population now. So the Globocan 2020 shows that the corpus uteri, the rate of is at the rate of 1.5%, and the mortality from this cancer is 0.7%. So if we talk about the risk factors of this cancer, other than the genetics, there are many hormonal factors which contribute to the occurrence of this cancer, which is polycystic ovarian syndrome, heavy weight, more increased BMI, diabetes, and physical inactivity, which I talked earlier also. So, according to one study on social media, Pakistan ranked ninth most obese country in the world. So the incidence of obesity, as I talked before, is also increasing day by day because of the sedentary lifestyles, and lot more awareness is required. So here you can see awareness talks about the obesity and excess weight on one of the websites, but if the incidence is on a rise. So WHO also warned about the cancer attributable to obesity, as two of the most common female cancers, breast cancer and the corpus uteri, constitute almost about 50% of its incidence. So the ovarian cancer. So the incidence of ovarian cancer, according to the Globocan 2020, is about 2.4% in Pakistan, and the mortality from this cancer is 2.5%. So the dilemma with the ovarian cancer is that it usually diagnosed in a very advanced stage 3 and 4 in more than 1/3 of cases. At that point in time, there is an intraperitoneal spread also with the involvement of our abdomen, and sometimes the chest is also involved at that time. And then the prognosis of this cancer seems very poor. So a study which is published in Biomedical Reports in 2017 had looked into the patterns of gynecological malignancies in southwestern region of Pakistan, which was an overview of 12 years, a retrospective study. So in this study, they showed that the ovarian cancer was found to be the number one cancer amongst the Pakistani population. However, it was done at a very small one center at a smaller level. So, and the ovarian, cervical, and uterine were again the three most common gynecological cancers. Another study, which was published in Pakistan Journal of Medical Sciences, shows the burden of advanced stage gynecological cancers. Again, this study shows the ovarian and cervical cancers are at the top amongst the women. And if you look at the table at the below part, so you can see very well that more than half of the cases, almost about 60-70% of cases, they do present in stage 3 or 4, where it has been spread to the upper abdomen and other organs of the body. So now talking about the hindrances to successful outcome of cancer treatment, we can very well say that there is unavailability of facilities at the National Health Service, as there is no National Health Service programs, no screening programs in our country. There are unavailability of expertise. The healthcare professionals are not particularly trained in this subspecialty. And of course, at the economic side, the cancer care is not a priority up till now. So talking about further this, a Pakistani-based US doctor who is working as a gynecological oncologist at Moffitt, he was talking to a social media and he said that in US, it feels like that only 30 to 40% of women, they get to see a gynecological oncologist if they are encountered with gynecological cancers. However, he said that probably in Pakistan, this rate is zero. So there are very, very, very few gynecological oncologists who are certified. So in our population, this is a big dilemma. And the women with gynecological cancers in Pakistan are usually being treated by the general surgeons, general gynecologist, or urologist. And they do their best, whatever they can do for them. So along with this, there is a lack of supportive care and comprehensive post-operative care, which again adds to the unfavorable outcome of these patients. So the second dilemma with us is that there is no cancer registry in Pakistan till now. However, we are very hopeful that now the Society of Obstetricians and Gynecologists of Pakistan are working on it and it will be soon available to be used by all. And then we can talk about our statistics in a more detail, because we believe that there is underreporting of all the cases and we do not know what is the actual prevalence of these cancers in our country. There are certain cancer registries who are working at the provincial level, like Karachi Cancer Registry, Punjab Cancer Registry, and Pakistan Atomic Energy Cancer Registries, who are working independently. So the history of gynecologic oncology is way back to beyond 50 years. In 1969, the subspecialty of gynecological oncology was formally announced. The American Board of Obstetricians and Gynecologists recommended the development of 3 subspecialties, out of which one was gynecological oncology, and the certification was approved by the American Board in 1973. So it is very, very important that the gynecological oncologist has to deal with the gynecological cancer cases for the better outcome, because the literature has proven this. When a cancer patient has been operated by the oncologist, their progression-free survival and the overall survival has improved significantly. So looking at the world, if we look at Pakistan, we don't have any subspecialty trainings which are now evolving. So in France, it's somewhere available, somewhere not available. In America, it is available. Other parts of the world are also having gynecological oncology subspecialties, which are very well formalized. But in most of the, you can see from this graph that most of the Asian and African countries are devoid of it up till now, 50 years after the evolution of this subspecialty. So in Pakistan, I'll be talking about the gynecological oncology subspecialty. Pre 2002, in a very big tertiary care center of Pakistan, Karachi, there was no faculty with formal training of gynecological oncology, and the senior consultants, OB-GYN and general surgeons, were combined to do these cancer surgeries. Then, going to 2002, they have trained one of their faculty from UK, and there was a formally trained gynecological oncologist trained, started its working in 2002. In 2008, another faculty was sent to Singapore for this same training to encounter the rising volumes of gynecological cancers. So there were two fully trained gynae oncologists on board. Then in 2017, another faculty was sent to Royal Marsden Hospital, United Kingdom, for the minimal access gynecological oncology training. So the work is going on, and we are hopeful that it will go further. Now, there are 3 certified gynae oncologists working and trying to train another gynae oncologist to counteract these cases in our country. So this is a picture of a gynecological tumor board. Whenever there is we want to alter a status quo, we have to put in a lot of efforts in terms of the pathology review, radiology review, and the complex cases review in gynecological tumor board to have the best management options discussed and the best outcome for the patients. So the range of activities provided by the gynecological oncologist is not only the clinical service in terms of outpatient clinics, oncology surgeries, colposcopy, tumor board, and minimal access surgeries. We also provide education in terms of our fellowship training, CMA activities, and public awareness talks. Other than this, the research is also of a need of the time to see what are our statistics and how can we improve this. So the hospital infrastructure, which is important to have this training, is constitute all of this to have a complete comprehensive training in this field. So the formalized fellowship training was started in 2013 with the overall goal of fellowship program to train young gynecologists to become academic gynecologic oncologists who are highly skilled and knowledgeable surgeons and capable of establishing new academic gynae-oncology units at other teaching institutions. So far, 4 of our fellows have been trained and sent to the different areas of Pakistan, including Abbottabad, Quetta, and in Karachi. And recently, we have taken a fellow in Punjab. This training is going on with the hope that one day the system will change. And I am very happy to share this with you all that the first gynecologic oncology surgery, which was done in KP, was also shown on the media, as this was the first gynecologic oncology surgery in that province. So this was the success. So other than this, the minimal access gynecological cancer surgeries are also provided and started with the cancer cases if they are at initial stages, and few of the borderline ovarian tumors and most of the endometrial cancer patients have been now operated with minimal access gynecological cancer surgeries. So in conclusion, I would just like to say that global cancer incidence is expected to rise by 75% over the next 20 years, and most of this increase is expected to be occurring in low and middle income countries. So expanding the trained workforce is crucial for future need. And the way forward is more fellowship programs are established in the country, and this fellowship program has been recognized by the central body, which is College of Physicians and Surgeons in Pakistan, to fulfill this goal. Thank you very much.
Thanks a lot, Dr. Uzma, for such an updated highlights regarding gynecological cancers in Pakistan. Now joining us, Professor Pushpa Sirichand. She is the Dean Faculty, Department of Obstetric and Gynecology, College of Physician
Hello,
and Surgeon,
everybody.
Pakistan. She is also an acting president, Urogynecological Association, and she is a chair of Obstetric and Gynecology Scientific Session Icon 2022 as well. We all know that PPH is still one of the leading causes of maternal mortality in low resource country, and there is a need to improve the knowledge and skills to prevent and medical and surgically manage such type of patients to reduce the mortality. So over to Dr. Pushpa, who will highlight on intervention beyond medical management of postpartum hemorrhage.
Hello, everybody. I am Professor Pushpa Srijan, working as a professor of OBGYN at ISRA University, Hyderabad. And I am really thankful to Indus Obstetrical Department for giving me a chance to give my presentation on management of postpartum hemorrhage beyond medical therapy. As you know that postpartum hemorrhage is still a major cause of maternal morbidity and mortality. To define primary postpartum hemorrhage, when there is a loss of 500 ml or more of blood from genital tract within 24 hours of childbirth, it is mainly divided into a minor postpartum hemorrhage when loss is between 500 to 1000 ml of blood, major postpartum hemorrhage when there is a loss of blood more than 1000 ml of blood. Now, it is further subdivided into moderate and severe. Severe when there is a loss of blood between 1000 and 2000 ml, and severe when there is a loss of blood more than 2000 ml or more than 30% of blood volume. Secondary postpartum hemorrhage is defined any abnormal or excessive bleeding from the birth canal between 24 hours and 12 weeks after delivery. Coming to the risk factors for postpartum hemorrhage, there are many risk factors like there are many risk factors like multiple pregnancies, previous history of postpartum hemorrhage, fetal macrosomia, failure to progress in second stage of labor, prolonged third stage of labor, retained placenta, abnormally adherent placenta, episiotomy, and mainly after instrumental delivery when there is an extension of episiotomy incision higher up and even up to the fornices. Genital tract lacerations and general anesthesia. Coming to the management of postpartum hemorrhage, all women with known risk factors should be delivered in hospitals with facility for blood transfusion and operation theater. Anemia should be corrected during pregnancy. BIM should be taken into consideration because women with a low BMI will be less able to withstand even the moderate blood loss between 1000 to 2000 ml because they have a very small circulatory volume. Now, how to calculate the approximate volume of the blood? That is booking weight in kg multiplied by 100 is approximate blood volume in pregnancy. We consider massive postpartum hemorrhage when loss of blood it exceeds more than 30% of total blood volume. So for example, a woman weighs 50 kg, her blood volume will be 5,000 ml, and loss of 15 ml of blood will be considered as a massive postpartum hemorrhage for that particular woman. We have to recognize obstetric shock due to hypovolemia, and there are few tips to recognize it. One of them, we should calculate the obstetric shock index. What is obstetric shock index? It is the pulse rate divided by systolic blood pressure. And this gives you an estimation about the amount of blood loss during third stage of labor. Now, in non-pregnant women, the obstetric shock index, it varies between 0.5 and 0.7. In pregnant women, it is between 0.7 to 0.9. And when obstetric shock index, it exceeds 1, it shows that there is a need for blood transfusion. Another important tip is never miss the golden first hour and rule of 30. What is the golden first hour? All the resuscitative measures, they should be started before estimated loss is more than 1/3 of women's circulatory volume. Or there is a change in hemodynamic status as it has been observed by obstetric shock index of more than 1. Golden first hour is the time to achieve maximum survival and prevent metabolic acidosis and organ failure. Always follow the rule of 30. This is a very significant sign of hypovolemia. When there is a fall of systolic blood pressure by 30 millimeters of mercury, increase in pulse rate by 30 beats per minute, hemoglobin concentration falls by 30%, which is equivalent to 3 grams per deciliter, fall in hemoglobin concentration by 30%, and estimated blood loss 30% of normal circulatory volume. What are the clinical findings in obstetrical shock due to postpartum hemorrhage? If you observe few points, that is blood loss volume, pulse rate, systolic blood pressure, signs, and shock. Between 500 to 1000 ml of blood loss, the blood pulse rate and systolic blood pressure, they remains unchanged. But you can observe the signs like palpitation, tachycardia, and dizziness. And there is compensated phase of the shock. If there is a loss between 1000 to 15 ml of blood, the pulse rate goes up to 100 to 120 beats per minute. There is a slight fall in blood pressure. The signs observed are weakness, tachycardia, and sweating, and she has a mild shock. If blood loss goes up to 15 to 2000 ml, then the pulse rate rises above 120 beats per minute. There is a significant fall in blood pressure, and the signs, they are restlessness, pallor, and oliguria. That shows a moderate shock. But when amount of blood loss, it is between 2000 to 3000 ml, the pulse rate may go more than 120 beats per minute. There is a marked fall in blood pressure, systolic blood pressure, maybe 50 to 70, collapse, air hunger, anuria, organ failure. And this is a severe type of shock, and usually there is decompensated shock and patient is difficult to survive. Always follow the 4 T's for causes of postpartum hemorrhage. That is tone, trauma, tissue, and thrombin. Most common cause for postpartum hemorrhage is uterine atony. Going to the initial management of postpartum hemorrhage, we should use the uterotonic agent, which includes the tranexamic acid, oxytocic agents, ergots. Then you can go to if it fails, we go for a uterine massage, which is carried out through the maternal abdominal wall. And if it fails, then we go for bimanual compression. One thing about bimanual compression is that it should be carried out up to minimum of 9 minutes. If there is a temporary measures for stabilizing hemodynamically unstable patients, or when we are waiting for an experienced person to arrive and help us, in these circumstances, we can go for aortic compression, either manually or with a balloon occlusion. Manual compression, there are 2 sites for compressing the aorta. One is few centimeters above the sacral promontory. Either we can use a closed fist or we can use the heel of the hand and apply compression. The other side is just below the origin of renal arteries. This is really a favorable site because not only it occludes the blood circulation into a common iliac and uterine arteries, but it also occludes the blood circulation in ovarian and inferior mesenteric arteries, which are supplying the uterus and the vagina. The patient not at imminent shock or extubation, then you shift the patient to theater, examine in a good light in a lithotomy position. And if you find any lacerations, either in the vagina or in the cervix, or sometimes there may be lacerations, especially when the instrumental deliveries are carried out, you find lacerations in the fornices. So examine them carefully under good light in lithotomy position, and if there are any lacerations or tears, they should be sutured. Then another method is uterine tourniquet. We'll discuss it later on. Uterine tamponade, which can be achieved with the balloon catheter or with a gas pack. We can apply compression sutures. We can do stepwise devascularization. And if all these measures fail, then we go for hysterectomy. And if she continue to bleeding after hysterectomy, we go for pelvic packing. Going to uterine tourniquet when patient is massively bleeding and we are waiting for a help, or we cannot find the bleeding point, then temporarily we can arrest the bleeding. We can apply a tourniquet, and this tourniquet you can use Foley's catheter, and it is applied as low as possible all around the uterus, and it temporarily arrests the blood flow through the uterine vessels. Other methods are, if they fail internal uterine tamponade, that can be achieved by insertion of balloon or insertion of uterine packing. This is a balloon tamponade. Now, commonly used in low resource country is a condom catheter. How it is being used? What we do is we take a condom and then we fix the lower end of the condom with a catheter, you can see that the condom, the lower end of the condom, we insert the catheter, we inflate the balloon of the catheter, and then we tie the lower end of the condom with the catheter with the help of a silk suture, and then we connect through the tubing to a drip. We pass this through the cervix into the uterine cavity, and we start filling the condom with either with a normal saline or with a sterile water. Usually about 300 to 500 ml of normal saline is required to fill the condom and to arrest the bleeding. We deflate this condom usually after 12 hours. And if she starts to bleed again, we can refill the condom and then remove the condom for after 12 hours. Intra-abdominal insertion of balloon catheter. Sometimes there is a bleeding from placental bed. What we do is we insert the simple catheter into the uterine cavity, inflate the balloon. We pass the lower end of the catheter from the cervix into vagina, and this really works. Uterine packing. In a uterine packing, the correct way of uterine packing is just catch hold of the fundus of the uterus with one hand, with help of a long forceps or with you, even with your hand, pack the uterine cavity, start packing the uterine cavity from the fundus, and it should be packed tightly, both the uterine cavity and the vagina. The packing of the vagina will provide a counter pressure and will prevent the slipping of the packet of the this packing from the vagina. This is if you don't properly fill the uterine cavity with a ribbon gauze, then there can be concealed severe hemorrhage within the uterine cavity, which may cause relaxation of the uterus, and it may be, patient may go into a shock, but it may be diagnosed very late. Then compression sutures. This is a B-Lynch suture. I will show you the procedure, how to do it on a video. These are the Hayman sutures. The advantage of a Hayman suture, these are the 2 to 4 vertical sutures which are applied. Advantage of B-Lynch is that this can be done without placing an incision in the uterus. If there is a uterine atony after vaginal delivery, perform laparotomy and apply compression sutures. These are the Hayman sutures. These are the coarse multiple square sutures. If there is a bleeding from upper part of the body of the uterus due to uterine atony or abnormally adherent placenta, then these sutures, multiple sutures, they are applied, and they are really helpful in controlling hemorrhage. Funnel compression suture. We have a very good experience with this funnel compression sutures, and I will show you a video demonstration of this later at the later part of this presentation. We apply 2 funnel sutures, and if patient continue to bleed from center part of the abnormally adherent placenta, then we insert the catheter, inflate it, and it controls the bleeding from abnormally adherent placenta. And this is known, if we combine together, this is known as sandwich technique. Then placement of figure of 8 sutures and other hemostatic sutures directly into a placental bed and myometer resection. If there is a placenta, abnormally adherent placenta, particularly placenta previa, and after removal of the placenta, there is massive bleeding from a placental bed that can be arrested by placing figure of 8 sutures. If she continued to bleed from thinned out uterine edges where the placenta was attached, we resect the portion of the myometrium and reconstruct the uterus. Stepwise devascularization, we devascularize the uterus by occluding the blood flow in uterine and ovarian vessels. For ligating the uterine vessels, what we do is you just raise the fold of peritoneum lateral to the lateral wall of the uterus and the uterine vessels. Here we can find in a broad ligament a avascular window. Just introduce your finger posterior to the broad ligament, you can find an avascular window, and pass your needle from posterior to anterior, and through this avascular window, take a bite about 2 centimeters from the myometrium. This will ligate the uterine artery. For ligating the ovarian vessels, what we do is just below the ovarian ligament, if you apply a stitch taking the myometrium into it, it will occlude the ovarian vessels supplying to the uterus. Even if they fail to control hemorrhage and we want to conserve uterus, particularly in primary gravida patients, then what we do is we go for internal iliac artery, and the procedure will be shown in video later at the later part of this presentation. If everything fails and patients continue to bleed, or if there is placenta percreta, which is penetrating into the broad ligament, penetrating into the bladder and the vagina, then we should not waste time on conservative procedures, and we straight away go with a cesarean hysterectomy. It will be difficult, but it will be life-saving for the patient. But sometimes, even after cesarean hysterectomy, patient continue to bleed. What to do in these instances? Here, if there is a generalized oozing, even after removing the uterus, that may be that the blood vessels, there is a blood supply to the uterus, not only from the uterine vessel, but even from the superior vesicle, inferior vesical arteries, and the inferior mesenteric arteries. They also supply to the lower part of the uterus and vagina, and the bleeding may continue. In patient in DICs, there may be thin watery blood oozing from all the pedicles and all side wall of the pelvis. In these circumstances, we do the pelvic pressure peg. Now, how to do this? We construct the bag. And this can be done with X-ray cassette wrap or any simple polythene bag, which is sterilized, and it is packed with a roll gauze. It is packed with a roll gauze, which are tied end to end, and they fill the dome of the pack, and the tail of the pack, it is drawn from the vaginal cuff through the enteritis. Then what we do is that we place this bag within the pelvis after hysterectomy. The tail end, it is drawn from the enteritis through the vaginal cuff out of the enteritis. And then we apply traction. The traction is applied to keep this pelvic pack within the pelvis and away from the bowel loops so that the bowel loops, they may not get adherent to it. And then we apply traction. We attach this tail end of the pack with 1 liter saline bottle. 1 liter saline bag, it is attached to the tail and it is drawn, bag is off the floor of the bed so that it applies traction to it and it remains within the pelvis. Post-laparotomy inspection, the operative field should be inspected carefully for hemostasis, and if there is any bleeding points, the hemostasis should be secured. Bladder and ureter should carefully be identified and inspected carefully. Now, the easy way to trace a ureter at time of laparotomy is, and particularly when you have carried out hysterectomy, what you do is you open the peritoneum between the, we open the peritoneum between infundibulopelvic ligament, lateral and parallel to infundibulopelvic ligament in a cephalic direction from the middle part of the round ligament. Dissect out the close connective tissue, you will find and trace the ureter very easily. I conclude my presentation. PPH is a major cause of maternal morbidity and mortality. Early diagnosis and timely appropriate management can save many mothers from this drastic complication of childbirth. Thank you so much for patient listening. You will be seeing few videos. One is on compression switches, other is on internal iliac artery ligation, and third one is on myometer resection in patients with morbidly adherent placenta. Thank you so much. We are describing the procedure of sandwich technique on this model. After reflecting the bladder, we take a stitch on 70 mm round body needle. Pass the stitch about 1 centimeter above the upper edge of the cervix and 1 centimeter medial from anterior to a posterior uterine wall. The needle is passed about 3 centimeter above the uterine incision from posterior to the anterior wall. The suture re-enters into the cavity about 1 centimeter above the uterine incision. The needle is taken out 1 centimeter below the uterine incision. The needle enters from anterior to posterior uterine wall about 1 centimeter above the upper edge of the cervix, comes out from posterior to the anterior wall about 3 centimeter above the incision line, enters into the cavity about 1 centimeter above the uterine incision and comes out of the uterine cavity about 1 centimeter below the incision line. We take 24 size Foley's catheter, pass the lower end of Foley's catheter through the cervix into the vagina, keep the upper end into upper part of the uterus. After closing the uterine incision, we tie these vertical compression sutures. We inflate the balloon to compress the center part of the uterus to arrest the bleeding. We have opened the abdomen by a midline incision and pecked the bowels in upper abdomen. This is the common iliac artery, which is dividing into external iliac artery going towards the lateral wall and internal iliac artery going into pelvis. This is a ureter which can be recognized by its peristaltic activity. The landmarks for internal iliac artery is a sacropromontory and the line joining two anterior superior iliac spines. And this is a ureter. We have to divide the peritoneum just lateral and parallel to the ureter for a few centimeters in a caudal and cephalic direction. Then once you split the peritoneum into medial and lateral folds, the ureter is always adherent with the medial leaf of the peritoneum. This is a common iliac artery which is bifurcating into an internal iliac artery and external iliac artery. External iliac artery runs over the psoas major muscles. Internal iliac artery, it runs medio-inferiorly into the pelvis. By gentle dissection, we separate the internal iliac artery from internal iliac vein. Now, this is a common iliac artery which is bifurcating into external and internal iliac artery, and this is a ureter. Now, we have retracted the ureter medially and the external iliac artery laterally to visualize the internal iliac artery. One must recognize the important relationship. This is the external iliac vein, which is lateral to the internal iliac artery. We have separated the internal iliac artery from underlying structures and will ligate it about 4 centimeters below its origin when it is given the posterior division supplying the gluteus region. The internal iliac artery, it has been separated from the underlying internal iliac vein, and we will ligate it about 4 centimeters below its origin. Now, the internal iliac artery, it has been ligated twice, about half centimeter apart, and you can examine the external iliac vein carefully as well as internal iliac vein for any injury and hemorrhage. Now we have opened the peritoneum on left side of the pelvis, and you can see this is an inverted V with the common iliac artery dividing into internal iliac, which is going medially and inferiorly towards the pelvis. Always separate the loose connective tissue in a longitudinal direction. Otherwise, you can damage the underlying vein. Now, this is a ureter which has been displaced medially. This is a common iliac artery which is bifurcating into an external iliac going over the psoas major muscle and internal iliac which is going infro medially towards the pelvis. We are operating on a patient who is 34 years old woman, para 4 plus 0. She is at 35 weeks of gestation and she has previous 4 elective cesarean section. This time she has been diagnosed as a placenta previa with morbidly adherence. You can see there are large blood vessels which are running into the serosa of the lower uterine segment. We will place an incision at the upper border of the placenta previa. We will not separate the placenta, which is morbidly adherent. We'll pass our hand through the incision and we'll see the lower border of the placenta. After resection of the entire myometer overlying the placenta, you can see this is the upper part of the uterine incision, and this is the lower end of the uterine incision, and we make sure that at least 2 centimeter lower uterine segment has been left behind for closing the left behind myometrium. This is the bladder, and this is the lower end of the uterine incision. Now we are approximating and closing the uterine incision. After performing the conservative surgery on the uterus by myometer resection, we will do tubal ligation. We have resected the portion of the myometrium where the placenta was attached, and the bladder has not been separated because the separation of the bladder in cases of morbidly adherent placenta can lead to a massive hemorrhage. And we have approximated the upper end of the uterine incision with the lower end of the uterine incision. This completes the conservative management of placenta perforata.
Thanks a lot, Dr. Pushpa, for such an elaborative step-wise management of postpartum hemorrhage along with the academic videos. Now we have a question answer session with the guest speakers. Assalamu alaikum to all of you. I have a question from Dr. Uzma. Dr. Uzma, how can we improve oncological services across Pakistan? As you have already highlighted many of the intervention which could be done, but the most important you think should be implemented to improve the oncological services across Pakistan.
Thank you very much, Dr. Aisha, for the very important question. So first of all, as I have mentioned already, that we have to develop our registry, we have to increase our healthcare workers training. But before that, I would emphasize from this forum that we have to increase the awareness at two levels. One at the public level, which is very important, and of course we need to make increase awareness of our healthcare professionals also to do the timely intervention at the adequate level. So we need to train our healthcare professionals, and with the training, we have to increase their awareness about the interventions which they need to do timely. Thank you.
Okay, thank you so much. I have a question from Dr. Hiba. Um, where would you like to see primary care services across Pakistan after 5 years? Especially, you are doing great job at Indus Hospital Health Network. I'm talking about all over Pakistan. Dr. Hiba, can you hear us? We are taking you on phone. Hello. Dr. Hiba, we are taking on phone. You can talk now.
Okay. So, primary care facilities that we have currently are in 9 districts of Pakistan, but are able to actually go across the country in all the districts of Pakistan. So,
Please, can you off your mic, please?
hello, can you hear me now?
Dr. Hiba, can you switch on your mobile speaker, please?
Can you hear me now?
Yes, we can hear you.
Okay. So, currently we're at 9 districts of Pakistan. Those
Speaker
districts with
on.
the lowest human development index. So there are six districts in the southern Sindh and six districts in southern Punjab that we're focusing on right now. The initial one was in Badin and in Sindh, and Rahimia Khan and Rajanpur in Punjab. So, but the aim is to completely cover all the districts of Pakistan.
Okay, thanks a lot, Dr. Hiba. Now, I have a question from Professor Pushpa. Um, as we all know that the morbidity in placenta incidence is increasing day by day because of increasing cesarean section rate. So, how would you like to improve training of a young gynecologist, basically to help to reducing the maternal mortality due to PPH? Because we have seen your academic videos, so how can you would you like to transfer to your knowledge and skills to the upcoming gynecologists to reduce the risk related to the morbidity in placenta especially?
Well, can you hear me? Can you hear
Yes,
me?
yes, we can hear you.
Okay. So what really we are now planning to decrease the incidence of doing hysterectomies, particularly in morbidly adherent patients, in very young patients, where we really want to conserve their uterus. We are conducting workshops on postpartum hemorrhage at not only in big hospitals but in small district level hospitals and basic health units, so that we can reduce the incidence of postpartum hemorrhage and we can early recognize the postpartum hemorrhage, and we can prevent the morbidity and mortality from postpartum hemorrhage. And my aim is to conduct these workshops in various hospitals within the country so that this skill can be passed to our junior doctors and they can learn easy methods and they can apply practically and reduce the mortality from postpartum hemorrhage.
Thanks a lot, Dr. Pushpa. Now I'm again inviting Dr. Pushpa for her concluding remarks at the end.
Well, it was a very nice session, and both the speakers they were spoken very well and on very relevant topics about the primary care. And I think this intervention is very important to reduce the maternal mortality, and still our maternal mortality is very high if you compare with the other developing nations. And these are the because I think the maternal mortality rate, which has been shown by demographic figures, it is even higher because many of the mothers they are still dying, and these maternal deaths they are not being reported. Therefore, primary care given to these mothers, I think, will significantly decrease the maternal mortality rate in Pakistan. And talking to the oncology, yes, gynecological cancers they are increasing. There's no doubt in it. And mainly the cervical cancer, it is preventable. It can be, the woman can be screened at early stages, and death from this cancer, it can be prevented. But still, we are getting patients at a very late stages with fistula formations. So I think early interventions and mainly the screening. If we improve the screening, we can prevent these deaths. So I think both the topics they were very relevant, and they have spoken very well, and that's the need of the day. Thank you so much.
Thanks a lot, Dr. Pushpa. Now, I would like to invite Dr. Samia Shuja for the vote of thanks. Dr. Samia Shuja is head of the Department of Obstetrics and Gynecology at Sheikh Saeed Memorial Hospital, Indus Hospital and Health Network. She is also co-chair of Obstetric and Gynecology Scientific Session ICON 2022. Over to Dr. Samia Shuja.
Assalamu alaikum. Before I formally thank to all those who made this session possible, I want to thank Allah subhanahu wa ta'ala who kept us safe and we survived the COVID wave. The theme of our conference this time is Beyond the Call of Duty. And we all know that the healthcare workers and their supporting systems, they worked day and night and beyond the level they used to work previously. And we reached a point where we could say that the Pakistan had less mortality. And we felt very proud. Alhamdulillah Rabbil Alameen. Thanks to Allah Almighty. After that, I would really like to thank my speakers. Hiba, who is a very diligent worker, who is supporting us at the Indus Hospital and Health Network platform for providing great services at the primary care level, and thus playing her role in promoting the role to reduce maternal mortality in Pakistan. So I really believe that the revival of primary care services is probably the key to reduce maternal mortality. Unfortunately, we in Pakistan have a beautiful healthcare system, but we were not able to deliver in that system. So this is high time that we revive our system and work at every level, thus reducing the burden at the tertiary health services. Coming to Dr. Uzma Chishti, again, a very dealing with the cancers is a very challenging task, and we all believe in prevention. And as she talked of the cervical cancer, there is a dire need to develop a national screening program and prevent the development of invasive cancer before there's nothing that we can do. Dr. Pushpa Sarichand, a great teacher, a mentor, an icon whom we always look up to. She delivered her talk on PPH, and as highlighted by Hiba and Dr. Pushpa herself, that PPH is the leading cause of high maternal mortality in Pakistan. I am very proud to say that during my tenure with Indus Hospital, I have almost completed 6 years with Indus Hospital. And Alhamdulillah, we did not lose a single life due to PPH. How did it happen? It was due to multiple contributing factors. The on top, I would say, are blood center, Indus Blood Center, which is always there to provide us with the quality blood and blood products. Then comes to our own system of OBGYN department, where we have a qualified obstetrician on floor round the clock to deliver services to our laboring women and the women who come to us in emergency with PPH and many other emergencies. And I must say that the system of on-call consultants, picking them from home and dropping them to the door of the facility, an integrated system has made it possible that we are managing PPH without losing any life. So here I would like to request all my colleagues who are attending this session that we need to play our roles, our bit. It could be very small, it could be very large. And when we work like a team, there's nothing small, nothing large. The ultimate outcome is actually what matters. So when we all together save a life, the credit goes to each one of us. And inshallah, we will be receiving our credits in the life hereafter. So I would like to thank once again Dr. Heba, Dr. Uzma Chishti, Professor Pushpa Sarichand for their valuable contribution to this session. I also want to thank the organizers for organizing and providing us all the support to arrange this session. May Allah help us safe and alive to arrange more sessions like this and learn from each other. Thank you very much.
Okay, last but not, thank you, Dr. Samia. Thank you so much for your kind words. Last but not the least, I would like to say again thanks to the ICON 2022 organizing committee at Indus Hospital and Health Network and all the guest speakers, Dr. Pushpa Sirijan, Dr. Uzma Chishti, and Dr. Hiba Arshad for giving us time and for such a nice presentations, and all the participants to take out time for attending this. And have a good day. Allah Hafiz.